Hi, everyone. My name is Lindsay Bowthorpe, and I'm a medical health officer at Fraser Health Authority. And I also recognize I am standing between lunch and presentation. So we have 7 posters that we're going to go through very quickly, and about 3 minutes per poster. We will not have time for questions, but the posters are out in the second room where you will be grabbing lunch, and you will have the opportunity to ask your questions at that time. So I believe we're starting with a pre-recorded session or presentation by Dr. Mark Gilbert. And if the other presenters could make their way over here while the presentation is going, that'd be much appreciated.
Good afternoon, everyone. I'm Mark Gilbert. I'm a public health physician at the BC Centre for Disease Control. Sorry I can't be there in person, but I'm here today on behalf of our team presenting our survey findings related to Mpox vaccine uptake in transgender people and gay, bisexual, and other men who have sex with men clients of our Provincial STI clinic at BC CDC. So as most people in the room know, I'm sure, BC launched a first dose Mpox vaccination campaign in July 2022, and this was promoted to transgender people and gay, bisexual, or other men who have sex with men, or GBMSM for short. Our health authorities partnered with providers, businesses, and community organizations like the Health Initiative for Men to implement the campaign. So we measured vaccine uptake and associated factors 6 weeks after the launch of the campaign. We did this by identifying clinic clients who had attended the clinic in the past 3 years and consented to be contacted for research and invited them to an online survey. The survey included questions about sexual and gender identity, about vaccine eligibility and uptake, and factors that might be associated with those outcomes, and we had a $200 prize draw. For this analysis, we focused on participants who identified as trans or GBMSM, and we used bivariate analysis to look at factors that were associated with vaccine uptake amongst eligible folks in this group. So overall, in our sample, we had 331 clinic clients identifying as trans or GBMSM. Of those, 66% who were eligible for the Mpox vaccine had been vaccinated with the first dose, and that's our measure of vaccine uptake. If unvaccinated, acceptability was high, and 85% were willing to receive the vaccine. So in looking at this in a bit more detail, being eligible but unvaccinated was associated with identifying as bisexual or heteroflexible, spending less time with other trans or GBMSM people, having less than 2 sexual partners or not attending venues for sex, not being aware that most cases of Mpox were amongst men who have sex with men, or about the symptoms of Mpox infection, having lower perceived susceptibility to Mpox and increased constraints to vaccine access, and reporting fewer cues to action. So fewer reporting knowing someone who's received the vaccine or with Mpox infection, seeing information promoting the vaccine, etc. Many of these folks did report challenges to accessing the vaccine. For 40%, it was related to physical access to clinics, such as distance or opening hours. For 22%, it was related to privacy or stigma, for example, concerns about being judged or having to disclose identity to access the vaccine. So overall, our uptake estimate of the first dose of the Mpox vaccine was high in this population. It's a lower mainland health-seeking population of trans GBMSM, so that may be higher uptake than we'd see in other BC settings. But our findings do speak to uptake being lower amongst folks who are probably more challenging and difficult to engage in promotion around vaccine using our available channels and methods for this population. And our findings really speak to the importance of intentional and ongoing efforts to engage diverse groups of trans or GBMSM in Mpox vaccination programs or other vaccine programs targeted to this population. Thanks.
And I would like to welcome Allison Griffiths for our next presentation. And Allison is a communicable disease surveillance analyst at Island Health.
Thank you. Good afternoon, everyone. Today I'm presenting on the invasive Haemophilus influenza type B outbreak among the underhoused population in Island Health. Due to vaccination, reports of invasive Haemophilus influenza type B, or HIB, are rare, with only 3 cases being reported from 2010 to 2020 in Island Health. However, from October 6, 2022 to November 25, 2022, 6 cases of invasive HIB were reported among unstably housed adults across 3 communities in the Island Health region, prompting an outbreak response. Because community-based outbreaks in adult populations had not been reported in the literature, nor experienced in BC, existing guidelines did not outline options to help manage this situation. So in collaboration with the Provincial Health Officer and the BC CDC, a novel response was created. The primary goal of our response was to decrease the incidence of invasive Hib among the affected population. The secondary goal of our response was to increase the general protection of circulating respiratory vaccine-preventable diseases through the concurrent offering of eligible vaccine. This included pneumococcal, COVID-19, and influenza. From this response, a total of 9 cases were identified. From those, 13 close contacts were identified. Of the close contacts, 92% accepted chemoprophylaxis and 46% accepted immunoprophylaxis, and none of these close contacts became cases. From November 21st, 2022 to February 15th, 2023, Hib conjugate vaccine was administered to 453 individuals, a part of a 1,500-person population, giving about a 30% uptake. Of those who received the Hib vaccine, 63% also received the pneumococcal vaccine, 45% received the influenza vaccine, and 40% received the COVID-19 vaccine. From this outbreak, revisions were made to the BC CDC Communicable Disease Control Manual guidelines to consider Hib vaccine for the management of clusters in small delineated populations. As well, enhanced surveillance was implemented across BC to help better understand the epidemiology of these adult cases. And finally, a formal evaluation is being conducted of the campaign to help better understand the factors affecting vaccine uptake among unstably housed adults. Thank you.
Thanks very much, Allison. And now we get to re-welcome Meghan Martin, who I have the pleasure of working with at Fraser. She is the regional immunization leader, and I will pass it over to Meghan for a presentation.
Thank you. I'm very excited to be here today to share Fraser Health's Immunization Outreach Services project. This is a 5-year research project funded by the Public Health Agency of Canada, which aims to identify populations that face barriers to childhood vaccination and test outreach strategies to see what works to overcome those barriers. In 2019, we identified 2 communities to receive outreach services. North Surrey and Chilliwack were selected as they had some of the lowest up-to-date coverage rates for childhood vaccinations, and they represented a mix of urban and suburban rural communities. Through the summer and fall of 2019, we conducted surveys and focus groups with 563 families. We asked participants to share demographic information, barriers that they had experienced to accessing childhood vaccinations, and factors that influenced their decisions to vaccinate. We also collected their child's personal health number so that we could assess which factors were associated with a child being up to date for immunizations. We found that up-to-date status was closely associated with socioeconomic status in the suburban community of Chilliwack, but less closely aligned in the urban setting of North Surrey. In both communities, those who reported an ethnicity other than white were on average less likely to have their children up to date for immunizations, but there were exceptions, with East Asians in both communities and South Asians and West Asians in Chilliwack being more likely to have their children up to date. Finally, those whose children were not up to date were more likely to report a busy schedule or childcare issues as barriers to vaccination. Based on this information, our research nurses identified community partners that could help us access these priority populations. Between 2020 and 2023, our nurses offered 297 childhood immunization clinics in sites such as family resource centers, community schools, shopping malls, and libraries. At each clinic, we asked the clients to complete demographic and client experience surveys so that we could assess which populations were accessing our services. Our results show that while clinics in both Chilliwack and North Surrey had approximately the same number of client interactions per clinic, Chilliwack provided immunizations to 91% of clients, while North Surrey immunized only 49% of clients. The North Surrey clinics provided more education, motivation, and record review, often with newcomers to Canada. Looking at the clinic locations, we found that shopping mall clinics served the highest volume of clients and were a good way to reach those who reported busy schedule as a barrier to vaccination. However, the Family Resource Center clinics were particularly successful in reaching a range of our priority populations. Clients reported that drop-in appointments, co-location with other services, and having clinic times that matched families' busy schedules were most helpful for ensuring they could access childhood vaccinations. So that's a very quick review of some of our initial findings, and I look forward to sharing more during the poster presentation.
Thank you, Megan. And I would now like to welcome Hannah Sell, who is a communicable disease epidemiologist in the Immunization and Vaccine Preventable Diseases Service at BC CDC. Welcome.
Thank you, and good afternoon, everyone. So today I'll be talking about 7th birthday measles vaccination coverage in BC. So as we all know, measles is a highly infectious viral disease that requires a vaccination coverage normally of 95% or higher to prevent sustained transmission. However, recent provincial immunization coverage estimates over the past decade have shown a decline in measles second dose coverage, and this appears to temporally coincide with the change in schedule for the second dose measles vaccine from 18 months to 4 to 6 years. However, it's been difficult to assess this due to changes in data sources that also occurred at the same time. So the aim of this study was to explore these declines a little bit further. So we conducted 2 analyses. First, we had a primary analysis, which used routine provincial 7th birthday coverage reporting data from 2014 to 2022. And data were obtained from a variety of sources, but previously we used to use individual level birth cohort data for our coverage numerator and then aggregate Ministry of Education enrollment estimates for our denominator. However, beginning in 2018, we started switching to individual level school cohort data for both the numerator and denominator. So to control for all these data source changes, we also conducted a secondary analysis for 2014 to 2021 using a single data source only. So this was just using the individual level registry birth cohort data, which we pulled both the numerator and denominator from. So overall, our primary analysis did find that second dose measles coverage declined in 2018 in all health authorities. And figure 2 on the poster there breaks it down. And beginning in 2018, more children had received first doses only than in the past, or were unimmunized and or undocumented. And then the secondary analysis using just the registry birth cohort data also showed this decline in coverage, and again with a higher proportion of children only having 1 dose only or being unimmunized or undocumented. So as these declines in coverage did persist across both analyses, even after controlling for the data source changes, this does provide support for the conclusion that the declines could potentially be attributed to program changes rather than data source changes. So a key consideration and take-home message of these findings is that BC could consider advancing the age of second dose MMR to 18 months, which is used in most Canadian jurisdictions, or use a mixed schedule where the second dose can be provided at 18 months or 4 to 6 years. And we should also focus on collecting missing immunization records to reduce the number of undocumented children and get a better picture of immunization coverage across the province. So thank you for your time, and if you have any questions, please feel free to visit me at my poster. Thank you.
Thank you, Hannah. And now I'd like to invite Phyumar Soe to the stage, and she's a graduate student at the School of Population Public Health at UBC. Can anyone translate?
Yeah.
Okay. Yeah.
So sorry.
No problem.
Go right ahead.
Hi, good afternoon. My name is Phyumar, and today I'm presenting one of my PhD thesis project that is COVID-19 vaccine safety among older adults. So we all know that elderly are particularly vulnerable to COVID-19 disease-related complications and even death. So like they are prioritized for COVID-19 vaccines.
So post-marketing safety studies are very important to monitor the safety. So the Canadian National Vaccine Safety Network has been active since the COVID-19 vaccine program rolled out in Canada in 2020. So for this study, we aim to estimate whether the first or second dose of COVID-19 vaccines was associated with serious health events. Here, what we mean by serious health event is that any health event that needed the medical emergency attention, something like they needed to go to the emergency department visits or hospitalization. Oh, yeah, here we go. So we recruited both vaccinated and unvaccinated participants from 7 provinces, territories across the Canada, and we do follow up the occurrence of health event within 7 days following immunization. And we do the same thing, 7-day follow-up for control participants. So overall, we more than 180,000 older adults completed for dose 1 survey, and for dose 2, more than 110,000 participants completed the dose 2 survey. Regarding the control survey, around 3,000 older adults completed the dose control surveys. So when we look at the serious health event, we see that the serious health event was less than 0.5% in control, as well as among the vaccinees for different vaccine products we commonly use in Canada. Things like Pfizer, Moderna, AstraZeneca. For misscheduled, that is for participants receiving different vaccine products for dose 1 and dose 2, we treat them as a misschedule. And when we do the multivariable analysis, adjusting for age, sex, and health status or previous COVID-19 infection, or maybe like provinces, we do see that any of the vaccine type we commonly use in Canada, that is Pfizer, Moderna, AstraZeneca, or misschedule, was not associated with serious health events compared to unvaccinated counterparts. So we want to conclude that among older adults, serious health events, within 7 days following the immunizations were very low, and they were not associated with the emergency department visits or hospitalization. With thanks, I would like to acknowledge our study participants and collaborators and funders. Thank you so much.
Thank you, Phyumar. And now we have Kate Twohig, who is an epidemiologist in the Immunization Programs and Vaccine Preventable Diseases Service at the BC CDC.
Yay. Okay. Thank you very much, everyone. I'm excited to share with you some findings of our study on the influence of prenatal care provider on routine vaccination outcomes in the first 2 years of life here in BC. So there were several threads of evidence that led us to want to explore this. We have seen that vaccine communication in the prenatal period can be associated with greater uptake of those routine immunizations in the first few months and years of life. We also have heard earlier that trusted healthcare providers can be a key determinant in uptake as well. And maternal care providers can have even stronger relationships. And then finally, we knew that physicians and midwives can have different approaches to how they communicate about vaccination and what they believe to be kind of within their scope of practice interacting with a client. So with these in mind, we aim to assess several different objectives of routine vaccination in the first 2 years, including complete vaccination by age 2, also known as up-to-date for age. We wanted to look at whether there was an association with frequency of refusals recorded on the immunization record, as well as if there were any delays of greater than 30 days for any of the typical recommended milestones in the BC immunization schedule at 2, 4, 6, 12, and 18 months. So I won't go through the methods in as much detail, but I wanted to say that we were using rich population-level data from birth registry, immunization registry, and medical service billing that were linked in the secure research environment of PopData BC. And we were assessing these associations using Poisson regression, adjusting for covariates we thought would be of interest. So as you can see in the results in the two figures, first of all, we included 180,000 children in our final cohort that were born between the years of 2010 and 2015, of which 16.6% had majority midwife care during the prenatal period. And all of the associations are shown in the two figures, but I wanted to highlight a couple main ones. So majority physician care was associated with 1.2 times the likelihood of being up to date for age by age 2, 0.4 times the likelihood of a refusal on the immunization record, and between 1.2 and 1.3 times the likelihood of there being no delay according to the routine milestones. One of the big things that we wanted to mention, though, is that one of the things we can't measure in this study is the intent to vaccinate by provider type. And we do know that there may be mothers who are choosing their providers based on their intent to refuse or not to vaccinate. But we do think that due to increasing frequency of midwifery use in BC and also our findings support the value of further investigating how midwives engage with their clients about the topic of immunization, and if there's any ways we can strengthen those communication ties and links to public health.
Thank you, Kate. And our last presenter is Dr. Nirma Vadlamudi, and she is a postdoctoral research fellow at the Vaccine Evaluation Center.
Thank you, Lisa, and good afternoon, everyone. Today, I'm here to present on RSV data, which was partially presented by Danuta, so I'll add on to the pan-Canadian data set. So I'm going to describe the respiratory syncytial virus-related pediatric severity disease in Canada. RSV is one of the leading cause of hospitalization in children under 5 years of age, globally as well as in Canada. About 16% of those who are hospitalized have one or more risk factors for severe infection. In addition to that, those who are hospitalized in their infancy have an increased threefold risk of developing asthma by the time they turn 5 to 12 years of age. Currently, the only medical intervention for prevention of severe RSV is available for high-risk infants, and that is pavlizumab's monthly administration of the injection, which makes it really complicated to do that for most of the infants. Unfortunately, RSV prevention landscape is changing rapidly, and there are several products in different stages of regulatory review, which makes this data review quite important and timely. There is maternal vaccine available for mothers to prevent RSV in neonates, and there is long-acting monoclonal antibody available for all infants if they are made available. Right now, they are in the approval stage. So today, we will go through the data that we have collected for the last 5 years and evaluate the severity that is seen in children 0 to 16 years of age through laboratory-confirmed RSV hospitalization across Canada. So in this prospective study, we are going to look at patients 0 to 16 years of age who are Canadian residents and have accessed healthcare at 13 impact hospitals for any of the 5 RSV seasons from November 2017 to June of 2022. Nurse monitors actively collected data and verified data on the date of admission, discharge, age of admission, as well as whether these children were admitted to ICU or what was the outcome of their stay. And then I have estimated hospital length of stay using admission and discharge date. Today we'll go through the case by the age groups as well as overall. There were over 11,000 RSV-associated hospitalizations throughout Canada. Half of those were in children under the age of 6 months. And if you look at all the hospitalization, about 24% led to ICU admission, and 21% had a hospital length of stay greater than 7 days. Overall, 63% of all the RSV hospitalizations were seen in children 1 year or under. And if we look into the age group further, we can see those who are 0 to 2 months of age constitute of 40% of the case count. And So the vulnerable group is 0 to 5 months of age group. 28% were admitted to ICU. 22% had hospital length of stay greater than 7 days. Of the total 29 RSV-associated deaths, we saw 73% in children under 5 years of age. So in Canada, RSV-related hospitalizations are frequent, and over half of them are seen in children under 6 months of age, with higher rates of ICU admission and longer hospital stays, which makes it important that we prioritize this age group for further RSV prevention program. Thank you, everyone.
Thank you very much to our 7 presenters and for sticking to our 3-minute timeline. I know that was a short period to explain important work, so please do visit them during the lunch break. And thank you, Dr. Devin Grayson, for keeping everyone on time by giving the prompts as to how much time was left. So I think just before we break for lunch, I was given a few housekeeping things to say. So lunch is in C100, which is over there. Enter through the double doors. You'll see an entrance sign. Once you've grabbed your food, please exit by the back door at the end of the buffet line. And there are tables. However, we think that there likely aren't enough tables for everyone to stay seated for the entirety of the hour. So please, once you've had a chance to eat, if you could vacate the table and give someone else an opportunity to sit and eat their lunch. I believe that is all the announcements, but I'm looking to see. Sorry? Slido? Oh, there's a Slido survey. So if you could go on to Slido, which you can find the link on your program, that would be much appreciated for completion of the survey. Thanks, everyone. Enjoy lunch, and we'll be back at 1:30.